And another point on the EUA. The EUA did not have certain selected automated extraction platforms that are in use in public health laboratories. So the rate limiting factor is the EUA is approved on certain instruments with certain extraction instruments, but it's for small numbers. That's not going to help us when we have every pregnant woman in the southeast part of the US needing a test. So we are collaborating with CDC and with FDA and with our own member laboratories in an intensive, quick effort to get those new automated extraction platforms done. Okay, other ones, surge plan. How are we going to work as a community, as a lab community, supporting other labs? There's reimbursement issues. Again, the validation is needed on those higher throughput platforms. Reporting for labs is actually an issue. Everything goes through ArboNet. ArboNet's great for disease reporting. It also has to go through an LRN reporting structure, and that's largely for reagent management needs, so it's more of a CDC need. And then the redirection of the FEP funds, we talked about that a little bit earlier. So here's where we are. At least 30 states and local labs currently have the 2 EUA authorized PCR testing capabilities. Others are implementing both that assay and also the serologic assay. 13 have validated the serology, more will come on. Coordination is still key, will continue to be key, and it's not just the laboratories in this network, it's the laboratories in your community. So the communication is going to be, at some point, send those specimens to the state public health lab or the local LRN lab or wherever. I do want to do a shout out for New York City. They have done a phenomenal job of communicating very, very technical information on the laboratory. So my hat off to you. Limited capacity. There's still limited capacity in our country. And the lab tests, they're good, but they're not great. So we still have some work to do there as well. So happy to answer any questions later. Thank you.
Thank you, Scott. And our last speaker this evening will be Dr. Umesh Shah. Thank you.
Thank you, Oscar. Thank you for putting this panel together. Thank you for all of you being here. We are between you and whatever you're going to have this evening. Chicken? Fish? Roast? Not sure exactly. So whatever it is, and I was just talking about food, not beverages. All right, so we'll leave that one alone. Welcome to Texas, and it's great to be on this panel this evening. And this is a really appropriate time and location for this conference, because obviously Texas is at a higher risk for Zika transmission, especially because we have the Aedes mosquito population. And so my job today, or at least I think my job today, is to provide a local perspective. And so that local perspective is going to be N of 1, right? So there are 2,800 local health departments across the country that NACCHO represents, and I'm going to be providing a perspective of 1. But I'm hopeful that that perspective of 1 then starts to really build the case that local public health matters, and that what NACCHO does and what organizations that are up here, my colleagues to my left, what we all do together in partnership really matters when it comes to really our fight against Zika and specifically our fight against the Aedes mosquito. So let me start by just figuring out how to, do I hit next? Thank you. All right, just figuring out how to advance slides. That's going to be the first thing I start with. So I'm the Executive Director of Harris County Public Health Environmental Services, and I would be remiss if I didn't mention what our community is going through right now in real time. This is from yesterday, and as you've seen with Tropical Storm Allison back early part of 2000s, we are now experiencing some of the worst flooding that we have had in a number of years. And this really brings to light some of the real challenges that we have related to Zika and even related to the Aedes mosquito, because we know right now, as water is flowing, that this is not the time that mosquitoes are breeding, because water is free flowing. But we know eventually the water will stand, and the water will stop, and the water will get into smaller areas like bottle caps and teaspoons and tablespoons, and the next thing you know, it's going to start to get dry, it's going to start to get hot, and the next thing that we see will be an increase in mosquito activity in Houston-Harris County. And so that is a significant thing for us. So when we're thinking about isolated events in our minds about emergency preparedness and response related to quote-unquote flooding, all of a sudden it becomes very real as we think about how that flooding may impact our response to Zika. And the picture on the left is our Twitter feed that's going as we speak, and we're getting a lot of messaging out, not just about Zika and Aedes mosquito, but really about prevention and some of the response activities with respect to the flooding. So I just wanted to start with that slide. So a little bit of information about our department and our county. We are the county health department for Harris County with over 700 public health professionals. Our jurisdiction is the third most populous county in the U.S. with 4.34 million people. We're spread over a size larger than the state of Rhode Island. Yes, so the county is larger than the state of Rhode Island, and we're politically, geographically, and sociodemographically quite diverse and growing in that diversity. And that's a challenge for us because folks that are going through the flooding today may not have been in our community with the Memorial Day flooding in 2015, may not have been in our community during Hurricane Ike, and may not have been in our community in Tropical Storm Allison. So we have to continue to get the message out on what emergency response and planning and mitigation, all the efforts together are all about. We're also fortunate to have the world's largest medical center in our community, but that said, that medical center, if you go 2 miles away from that medical center, you'll have some of the country's most stark health inequities that you can imagine. What we do in public health, and this is our department's story, but it's a story of all of us in the room, and what we do is really behind the scenes. And so when we do restaurant inspections, water quality looks, or emergency preparedness, or mass vaccinations, or immunizations, or community engagement activities, or picking up dangerous dogs, or my favorite, and we kept the mosquito alive for this slide, so it's still flying right now, but by the end we're going to zap it, is our mosquito control efforts. Is what we do when we do our job behind the scenes, and so you oftentimes don't know what we do. That's the story of public health. And really the story of mosquito control in our community is really 50 years of this, right? So in 1964, we had St. Louis encephalitis. Harris County taxpayers decided on mosquito control district. In 1965, it went operational. 50 years later, last year, we commemorated 50 years of mosquito control activities. We have a lot of milestones in that. 1985, we characterized or identified Aedes albopictus, the Asian tiger mosquito, for the first time in the continental U.S. In the early 2000s, West Nile virus came to our community. But the story for our mosquito control program, as great as it's been or how recognized it is that it has had decades of work around the Culex mosquito. And only in the last few years have we moved towards the Aedes mosquito with dengue, chick V, and now with Zika. So fighting the bite has really been a lot of the activities that you see here with the Culex mosquito. Again, outside of avian surveillance, all of these activities really fall in line with what we do and are planning on doing with the Aedes mosquito for Zika. So our approach to Zika is very much first knowing where the mosquito is and what's happening in our community, what's happening in Texas. Unfortunately, we have both of the species of Aedes albopictus and Aedes aegypti, and if the map that I was hoping that we would be able to show all of you is that is the case for many communities across the United States, especially all communities within Texas and the Gulf Coast. We also know that we have to shift from Culex-based mosquito activities to now incorporating Aedes mosquito. But that's a challenge because people are still going to die of West Nile virus in our community. And so we need to do both. It's not an either or, it's an and. And that also means it's a different kind of mosquito, right? So the Culex mosquito is a nighttime mosquito generally. The Aedes mosquito is a daytime biter. It stays close to the ground, stays close to the home, stays in the home, whereas the Culex mosquito sort of flies around. So we can send our trucks out in the middle of the night and actually do spraying operations, even if the community doesn't do public education efforts, are not as effective in personal protection or source reduction. Our trucks still come as the silver bullet in the middle of the night to spray for the Culex mosquito. That changes with the Aedes mosquito because we're not as effective in utilizing those strategies. And then we really believe that One Health and health equity are approaches that are really part of that real fight against the Aedes mosquito. So from a health equity standpoint, we know just telling our community, go out and buy stuff, go get screens and go access the healthcare system and go see your doctor if you have symptoms. That's a big challenge when folks do not have all the perhaps the resources or the socioeconomic factors come into play. So it's a real challenge for us to really get the message out to people. While we also have to recognize that in our department, we're fortunate to have a One Health multidisciplinary approach where we have animal health, human health, and vector control all in one house. So we would be foolish if we didn't utilize those efforts together. And that's what we've done with our fight against Aedes, to actually have a multidisciplinary team that comes together as we approach the real prospect of what we're doing moving forward. Our response levels are very much aligned with how emergency management has response levels, moving from level 4 all the way to level 1. And level 4 is normal conditions, no cases of locally transmitted Zika in Harris County, moving to 1 case of locally acquired, to few or cluster of cases, to eventually widespread Zika throughout our community. And this picture is our Zika response team that started back in January 7th of 2016. So for us, it wasn't just theory, it was practice. January 11th, we went live with the first Texas Zika case, travel-associated Zika case. We had to do a press release, we had to get all the information out, and the moment we got information out, it was like a boomerang. Everything came back our way. We had national media, we had international media, because it was the first Zika case in Texas and one of the first in the US. And why that was really challenging was that we needed to come up to speed very quickly on Zika. So before I went overseas right over the holidays in December, my staff, my mosquito control director, was talking about this 4-letter word called Zika. I was like, yeah, I'm going overseas. I don't know what you're talking about. Yeah, we'll get to it, right? I come back and we were getting to it. And so that's a real big challenge. All of us in public health, how do we learn new emerging infectious diseases? Our focus areas around Zika are very much preparedness and response, obviously as an overall umbrella, but vector surveillance and control, epidemiology surveillance and testing, healthcare intersection with our clinical community, and certainly communications and engagement. In red, that's what I'm going to focus on, but what's in black is absolutely critical behind the scenes of legal review and authority, making sure our environmental folks are part of this, and also even our zoonosis and veterinary public health folks. So with vector surveillance, we have historical data on the Aedes mosquito, but it's not a lot because that's not what we were focusing on. So we have limited data on the Aedes mosquito. Now we need to ramp up and get information about what's happening with the Aedes mosquito throughout our community, including mapping, including metrics, including all the different kinds of trainings and equipment and all the materials that are needed for our community, for our department and our employees, while we also work with our community and our partners so we can reduce mosquito habitats and make sure we get the word out about Aedes. We have divided 1,778 square miles into 268 operational areas. Based on where the diseases are with our trapping, that's where we go out and actually come back and decide that's where we're going to then spray and do interventions that are going to reduce the amount of mosquitoes that are in that area. So we figure out where the disease is, then we target the intervention by sending our sprayers, et cetera, to do various things. What you can see in the yellow and blue, that's what we do for Culex mosquitoes. But what you can't see as well is that in red are the areas where we have currently traps in for Aedes mosquito. But in green, that's where we want to add additional traps. The traps are themselves not that expensive, $200, $150, $300. But the challenge is what you see on the very right. It's not just the trap. It's the person that has to do something with the trap. I mean, setting it up, making sure it's working, going out, picking up the mosquitoes, going out and bringing those mosquitoes back on a daily basis or weekly basis, and then again, bringing them back to the laboratory and do virology testing and all the surge activities that go with that. All of a sudden, you're talking about a lot of dollars that are not just about a $150 or $200 trap, and that's a really key piece for us. From the human surveillance side, we may be doing mosquito control and vector control, and I would ask the audience, and you would say maybe 20-30% of folks in the audience would say, yeah, we do too, but all of us do this piece. Human surveillance and outreach. All of us have epidemiologists. All of us are making sure we know what's happening in our healthcare community and working with our healthcare community. Getting that information out is a critical piece to this, and we have to continue to make sure that public health works very closely with our healthcare sector. And it's about communications and engagement. At the end of the day, communication is a critical piece of this. We have to make sure that our community understands what they can do to protect themselves, because it's a partnership with us in public health and what's happening within our community. And I think this is a key message. And this is a message that NACCHO has put out there, that ASTHO has put out there, that the CDC has put out there, that we've had from even WHO on a global spectrum, and certainly here in Texas with the Texas Association of City and County Health Officials. What we need to do is really make sure that people understand that it's a partnership, all partners working together so we can get a common message out to our community, and we can continue to make sure we accentuate it in the communities that are more vulnerable than others related to Zika because of travel association or because of a lot of back and forth travel to other countries where Zika is present. So let me close with 2 slides here. Zika response challenges. I think this is key. The situation related to Zika is one that continues to evolve, and I think all of us will vouch for this. When you heard from folks, when my colleagues were talking about, I'm not sure we were ever going to be talking about genetically modified mosquitoes, or another colleague talking about sexual transmission. A year ago, 6 months ago, none of this was on the table. Today, it's all on the table. So we have to be mindful of what's happening with Zika and make sure that we're able to be as nimble as the situation requires. And we cannot spray our way out of this. That's a quote from me, by the way, so I'll put it in quotes. We can't spray our way out of this situation, right? So we think that spraying is the magic wand. In this case, it may be targeted spraying, but it's really source reduction, it's education, it's personal protection, all the things that our community needs to do to pick up various sources of breeding in the community. I've already said this, I'm not going to say it too much longer, but Culex-based mosquito plus Aedes mosquito together is an additive arbovirus response, and we need to make sure that we try to put that all together. Zika is happening, but so is diabetes, so is obesity. We have people that are still dying from other infectious diseases in our community. While we do all of this, we have to also be mindful of all the other things that get moved to the side while we respond from a Zika standpoint. And that's important when funding and resources aren't all there, or they're not broad-based funding resources. And so what I would just say there is that 98% of our vector control, our mosquito control program, is paid by local dollars. And in some communities, I would say 100% are paid by local dollars. That's provocative, and that's something that we need to be really thinking about. How do we get policymakers to understand that dollars need to get to local communities? Final slide, role of local public health just makes common sense. This picture on the right is from an ICS 213 from Hurricane Katrina response back when I had hair and it was not all gray. In 2005, and it was 2 o'clock in the morning, and instead of asking for widgets, I was asking for common sense, and I think that's something that's stayed with me. So you got, outside of my Twitter feed and all that, USHA-MD and HC Fez, what I really have right there are pictures of our people that are responding to Zika. Our team has been at this for several months, and I really want to recognize all their efforts. Thank you.